All right, welcome everyone. We're going to go through some more test taking. We'll pick a USMLE question and dive right into it, see how it goes. I'll try to hit step 1 and step 2 related concepts. That way it's useful for everyone. That way you can see kind of like the whole big picture as well. For me, even whenever I was studying for step 2, if I couldn't remember some of the pathophys or exactly how something worked, it always made more sense to me to go back and actually learn and review some of that step 1 stuff. All right. So I'll give you guys a second to read it, and then we'll dive into it. All right, so starting at the end, which of the following is the most likely cause of the patient's new symptom? So we're looking for something that causes a symptom. So our intention is what is the cause of symptoms? So whenever you see a question that your intention is what are the cause of symptoms, you want to start thinking, well, what is associated as either a side effect or a subsequent sequelae or something along those lines for whatever the main pathophys is. All right, so a 32-year-old man comes to the ED because of a 4-hour history of sudden onset of severe headache. He has neck pain and vomiting. So that's obviously all important. He has poorly controlled hypertension and uses cocaine, which also is probably important. The neuro exam shows no focal signs. That's important. Because if you have focal signs that are lateralizing, then that will definitely push you one way or another with your diagnosis. And it says that he is unable to flex his neck because of pain. So first thing that kind of comes to mind whenever you hear flexing the neck issues, I start thinking of maybe meningeal irritation. And most people jump straight to meningitis with this. So I'm going to put this here, but I want you to also realize that it's not just meningitis, like the classic infectious sort. It can also be meningismus, which is basically just meningitis-like symptom due to irritation of the meninges. So a non-con CT scan of the head reveals blood in the sylvian fissure and the basal cisterns. All right, so there's blood in the sylvian fissure and basal cisterns. So you already should know what the diagnosis is based upon these CT head findings. All right, so I'll tell you in a minute, but any time that you see blood in the basal cisterns, that's a dead giveaway on the question. The patient is admitted to the hospital for treatment. By day 4, his headache has improved, but he suddenly develops acute right-sided weakness. So he's now got a new issue. A CT scan does not show any changes compared to the initial scan. So this is a really classic thing that you'll see. And it's classically tested because it's so high yield for real life. So again, which of the following is the most likely cause of the patient's new symptom? So first off, we find the new symptom, and it's going to be acute right-sided weakness. And so he had acute right-sided weakness after he was found to have blood in the basal cisterns. So the first thing that you need to jump to is what's the actual diagnosis? So the diagnosis is going to be subarachnoid hemorrhage. So it's basically definitive for the all intents and purposes on your boards that if you see blood in the basal cisterns with a presentation like this, you should jump to subarachnoid hemorrhage. And so other ways that they can say that on the radiologic findings is, number 1, they can actually say hyperattenuation of the sulci and or basal cisterns. And that just means that there's blood. And so don't let the word hyperattenuation throw you off. And that's gotten me before, is I wasn't really sure what they meant by hyperattenuation on the question stem. And so they're actually just talking about blood that was on the sulci as well as in the basal cisterns. So be on the lookout for that. So I'm going to put a pink star by that because that's something that got me before on a test question. All right. So how do you get subarachnoid hemorrhages? Let's talk about the epidemiology. So first things first is it's usually either due to a trauma or it's due to a rupture of a berry aneurysm. Those are the most common instances that you'd have a subarachnoid hemorrhage. Not to say that there's nothing else. Like you can get it from an arteriovenous malformation. So an AV malformation can actually give you a subarachnoid hemorrhage too if that ruptures. But usually it's a saccular berry aneurysm. And so you need to know the word berry aneurysm, and you also need to know that saccular can also be used to describe the subarachnoid hemorrhage, berry aneurysms. So they can interchange these two words. The toughest thing on your step 1 and step 2 is not getting thrown off by those little words like hyperattenuation or saccular aneurysm. So definitely keep kind of like a mental log of when you see those words interchangeably, which on the question stem, they're not going to give you both words. So that's why I'm telling you right now, that's one instance where it's interchangeable. And so you can actually learn a lot from this question that I want to point out. So this is actually a step 1 question, but we're going to show you how you can learn material for step 2 while you're actually learning a step 1 question. So if you look into the question stem, they actually tell you how to diagnose a subarachnoid hemorrhage. And so it's a non-con CT. This is super important. This will be a question on step 2 for you, whether you're in your UWorld or on your actual exam. You need to know that a non-contrast head CT is the first test of choice for subarachnoid hemorrhage. So what if a non-con CT doesn't show you any blood in the basal cisterns or anything that would give you the inkling of a feeling that it's actually a subarachnoid hemorrhage? Well, then the next step is going to be to do a lumbar puncture. So test of choice, TOC, is going to be non-con CT. And then if that's equivocal, meaning it doesn't really tell you one way or another, it doesn't confirm or deny that you have a subarachnoid hemorrhage, then you're going to do a lumbar puncture. So that's going to be super high yield for step 2, is knowing what's the next best test if the CT is not useful. The thing that you need to know for step 1 is what can you actually see in the lumbar puncture? And not to say that you don't need this for step 2, but generally by step 2, you know this. And so you'll see one of two things, either blood or xanthochromia. And so if you haven't heard the word xanthochromia before, you certainly need to know it. It basically means that you have a yellow tap. So whenever you do a spinal tap with your lumbar puncture, the CSF appears yellow. So I'm going to write that in here just so you have that. So that's going to be yellow CSF. And that's really big because they could actually just give you, patient comes in with a headache, they have a lumbar puncture that confirms xanthochromia. What's the diagnosis? Boom, subarachnoid hemorrhage. That's another way that they could flip this concept and ask you with a little bit more trick to it. Okay, so let's talk about incidents, because oftentimes on step 2, they'll ask you, well, what's the most common cause of this? So like I said, trauma is going to be number 1 most common cause, but also number 2 is going to be a rupture of a barisaccular aneurysm. But you can actually get a subarachnoid hemorrhage that is completely out of nowhere, essentially. And so these patients can actually have a predisposing factor such as high blood pressure, cocaine use, or even caffeine use if it's really aggressive. And so if you look in the question stem, you just learned something else here. Hypertension and cocaine, risk factors, boom. Okay, so who's more likely to have these berry aneurysms? Because I'm going to show you how that they can take this to a whole different level for step 2. So it says this patient has a ruptured barisaccular aneurysm. What other symptoms may this patient have? And so, of course, you're just immediately jump to the subarachnoid hemorrhage and you're trying to brainstorm, well, what else would they have? Is it a stroke? Like, what else could this patient have? And so you want to be on the lookout for stuff like Ehlers-Danlos, or they might even have autosomal dominant polycystic kidney disease. So I'll just put ADPKD, so autosomal dominant polycystic kidney disease. And so this is how questions can get really, really tricky. And this would be like a 30% or so on UWorld of people that would get this right. So they do this whole description of a subarachnoid hemorrhage, and then they say, what else should you look for in the patient? And so they might have something like hypermobile joints, or they might have aneurysms in their liver, or mitral valve prolapse, or something like that. And so you should definitely keep that sort of a question on your differential. And this is how you start to chunk material together, so you can really memorize like 5 or 6 different parts of information to make yourself a better clinical picture. So your guys' homework is to go and back and review what autosomal dominant polycystic kidney disease and Ehlers-Danlos symptoms would be. Okay. And so now let's take it to anatomy, which you guys know I always love taking it back to anatomy. So if you have a saccular aneurysm, where is it most likely to be located? So these berry aneurysms, I'm going to just put a circle here. And we're going to talk about anatomy. These are going to be at the communicating arteries. So you have an anterior communicating or a posterior communicating artery. And so in your circle of Willis, these are the 2 most common locations that you have a saccular aneurysm. And this is actually a question that I've seen before. So you need to make sure that you know it's the communicating arteries. It's not the anterior cerebral or the posterior cerebral, it's the anterior communicating artery and the posterior communicating artery. That's another thing that I got tripped up on before because I didn't realize it was the communicating branch. Okay. So classic thing that people know about subarachnoid hemorrhage is they usually say it's the worst headache of your entire life. It's somebody that has like a thunderclap headache. And oftentimes they're not going to give you that in the question stem for a legit question. Maybe if you're doing like USMLE RX or something like that to get yourself warmed up, you might see that phrase. But in actual USMLE or UWorld or even some of the complex questions, they might not say worst headache of your life. And if you look in this one, they actually didn't say that. They said severe headache, but they didn't say worst of his life. And so if you don't see that in the question stem, don't let that throw you off. And that's something that I wanted to touch on this question for, because a lot of people don't have subarachnoid hematoma on the top of their differential if they don't see that phrase. Okay, so what you need to know about this patient's presentation is he has something called a sentinel headache. And so a sentinel headache is important with a subarachnoid hemorrhage. And so what it is it's basically a severe recurrent headache that may be even weeks prior to the hemorrhage. So it could be days to weeks prior. And so that's exactly what this guy had. So it said that he had this severe headache, neck pain, vomiting, and then he had all these other symptoms. And so the sentinel headache often throws people off in the test. And just to recap, like we said, you see somebody that has this, if you even have a little bit of suspicion, especially if they have either autosomal dominant polycystic kidney or Ehlers-Danlos or severe malignant hypertension, cocaine use, maybe like 15 energy drinks of caffeine intake, something like that, then if they have that type of a headache that's severe, you want to get the non-con CT. If that's equivocal, you can go to lumbar puncture. Remember, the 2 things you'll see is either blood or xanthochromia. Okay. What is your management guidelines for this? So let me add a page here so we can dive deeper into this. So management, which is obviously going to be extremely important for step 2, but it is making its way into step 1. There's actually one question in UWorld for step 1 that asks on this. And so what you want to do is systolic blood pressure less than 150. And that's going to be important to also keep note that you don't want this patient on any kind of anticoagulation. So you want to stop anticoagulation because they're just going to bleed even more. So if the patient's on like a heparin drip or something like that, you want to stop it. And once you've controlled the blood pressure, usually patients will get labetalol for IV to basically drop the blood pressure and get them controlled quicker. Then what you want to do is you want to start worrying about secondary ischemia. And so afterwards, anywhere from 3 to 10 days after the hemorrhage, you have something called vasospasm that can occur. And so I'm going to put a star by this because this is asked year after year after year. So 3 to 10 days after the subarachnoid hemorrhage. What's the most common morbidity that occurs? It's going to be vasospasm. And I'm going to even write all this out here because this is straight from UWorld. So it's the most common morbidity from a subarachnoid hemorrhage. And so there's a way that you can actually prevent that vasospasm, and this is really important. You want to use nimodipine. And so this is your TQ, nimodipine. They asked us for all the test questions for step 1 and step 2 is how do you prevent vasospasm? So you use a calcium channel blocker, but you have to know that it's specifically nimodipine. You can't just give them any old calcium channel blocker because that will not be correct on your test. Nimodipine is the best choice. So something that you should avoid in these patients, which I'm going to dive into just because it's also something that can get asked, is anything that would increase your intracranial pressure. So any drugs that increase intracranial pressure. And patients that you're seeing commonly, they'll have like nitroglycerin for their MIs or anything like that. And so a lot of the nitro drugs will increase intracranial pressure. So you want to especially avoid nitroglycerin and nitroprusside. The nitro drugs are kind of infamous for increasing your intracranial pressure. So make sure that you make note of that. Okay. How do you actually treat these patients besides medically? Well, the definitive surgical treatment is going to be clipping. So this is more of a step 2 concept. So for surgery, you can do aneurysm clipping, or you can shoot some metal coils into the aneurysm. All right, and that's a little bit lower yield, but that is something that comes up from time to time, rarely on step 2. So clipping or metal coils. So if here's your little aneurysm, you can basically just clip it off, or you can just take some metal coils and shoot them into there and basically plug it off. All right, so those are really some of the biggest things that you need to know. So let's just do a quick recap. If the question asks you, what is the most common cause of morbidity and mortality after a subarachnoid hemorrhage, you immediately want to say vasospasm. That's going to be your answer. Something that's important to note, which is also noted in this question, but I'm going to point out here, vasospasm is going to not be seen on your CT because it's just the vessels that are clamping down. And so this is important because let's go back to the question stem here. It says here, by day 4 in the hospital, his headache has improved, but he suddenly develops acute right-sided weakness. A CT scan does not show any changes compared to the initial scan. So here it is, it's vasospasm. And that's one way that you can solidify your answer, that this is actually G, vasospasm-induced cerebral ischemia, because you're seeing that there's no change on the CT. And so if there was a rebleed or an increasing bleed or hydrocephalus or anything like that, then you would see that on the CT scan. And so you can easily look through some of these other answer choices and knock them off with at least relative confidence. So embolic stroke, boom, there's no changes on the CT. Hydrocephalus, boom, there's no changes on the CT. So it can't be any of these. Rebleeding, you know it's not that because there's no changes. Again, F, thrombotic stroke. You can nail off like almost all these just by that one line in the question stem. So that's why it's so important to not just skim over stuff, even if it's negative. So that's like really one of the learning points that I want to talk about with this question in terms of test taking. And this is where a lot of people get tripped up. If they see something that is negative or normal or doesn't give you any positive information about the case, they immediately just write it off. But if you look here, I had initially underlined this part of the question stem. Even though it said that the CT does not show any changes, that's an important clue. So really, I want you to just take with you today that even though there might be something normal or unchanged in the question stem, don't immediately write that off as not part of the entire clinical picture. So that's just to keep a high suspicion to make sure that you don't miss stuff like this. Other things that I want to talk about with subarachnoid hemorrhage is the initial hemorrhage itself is non-focal. And so if you look at the beginning of the question stem, it says severe headache, neck pain, vomiting. He has no focal signs. So again, another thing that you can actually learn from the question stem itself. So he has no focal signs, but he is unable to flex his neck because of pain. And so the reason he has this meningismus is because the blood actually leaked into mixing with your CSF, and it's irritating your meninges. And so blood is basically just an irritant to the meninges, so it can present like meningitis. And a lot of M1s and M2s, they get tripped up by that just because they see the Koenig or the Brudzinski sign. Like if you remember with the Koenig sign, it's you bend your knee, you have trouble. And then with Brudzinski, it's how this patient presents with flexing his neck, causing pain. So watch out for those Koenig or Brudzinski signs, because it doesn't have to just be like viral meningitis or bacterial meningitis that causes those. It can also be from meningismus. And that's another thing that I actually didn't realize until I was studying for step 2. And so that is basically everything you could be asked in any shape or form for step 1 or step 2 on subarachnoid hemorrhages. So that is how I would work through this question. If you know that vasospasm-induced cerebral ischemia is going to help guide you as what's the most common morbidity and mortality after subarachnoid hemorrhage, which you correctly diagnosed by the non-focal signs, as well as the meningismus. The dead giveaway in this question, however, is the basal cisterns. So you wouldn't even need to read like any of these other details if you didn't technically want to, which obviously I don't recommend that, but just in terms of overall information on the test, you could get to the information just by seeing that there is blood in the basal cisterns, and you could assume that the complication was vasospasm-induced cerebral ischemia. The fact that the CT scan doesn't have any changes supports that. So that is really the major things for this. I would work through this question, and this is a type of question that you want to click and move, because you either know this or you don't know this. And so anytime that you feel overwhelmed with any of these intracranial hemorrhages, whether it's epidural, subdural, subarachnoid, or intraparenchymal, you need to sit down and think about what you know for the basics. And so I'm going to talk about intraparenchymal hemorrhage briefly here, just because it was something that I would commonly get confused with. A lot of people are good with epidural versus subdural hematoma, but when it comes to intraparenchymal or subarachnoid hemorrhage, that's where it gets a little bit more tricky. So let's talk about intraparenchymal hemorrhage. Let me just add a page here. All right, so intraparenchymal hemorrhage. So the most common cause of this is going to be hypertension, which can also be associated with subarachnoid hemorrhage. So that's one reason why people often get these confused. There's a step 1 question that hits this from a hard angle that I want to touch on. And so you can also see these intraparenchymal hemorrhages in patients that are older with Alzheimer's dementia. And so they often have amyloid angiography. And I apologize if you hear my pager in the background. All right, so amyloid angiopathy. And so these are patients that maybe have a bunch of amyloid buildup with age, and they get a recurrent lobar hemorrhagic stroke. And the key here, the key word I want you to know is that it's going to be a lobar stroke. And so these patients will have it in the same exact lobe of the brain, whether it's the temporal lobe or whether it's the parietal lobe or wherever it may be. It's going to be the exact same lobe. The most common lobes that will be affected, and this is important, is going to be your parietal and your occipital lobes. So it's going to be either parietal or occipital lobes 9 times out of 10. Okay, and so that's an easy TQ for you if you know the anatomy for that. Kind of if they got a parietal stroke, what would you expect? Well, it's usually going to be some kind of a contralateral hemisensory loss. And then if it's an occipital lobar hemorrhage, then oftentimes they have a homonymous hemianopsia. So those are like really the top things that I would think of for the recurrent lobar hemorrhagic stroke seen with amyloid angiopathy. And so you want to look for patients that have like Alzheimer's. All right, so it's either the parietal or occipital lobe most commonly. Anytime you see these intraparenchymal hemorrhages, don't get thrown off by the other wording that they can actually say. So they could say even intracerebral hemorrhage, which means the exact same thing. And oftentimes, like layman's terms, they'll just call it a hemorrhagic stroke. And so I said hypertension is the most common cause, amyloid angiopathy. You can also see it with some AV malformations, as well as patients on anticoagulation. So a lot of those risk factors are similar between subarachnoid and intraparenchymal. So you want to basically take note that these are going to be focal deficits. So this is a big difference between the subarachnoid and then the intraparenchymal. So I'm going to put a big star by this. So it's focal deficits. So I'll just say subarachnoid hemorrhage is non-focal. The thing that would be focal for a subarachnoid hemorrhage could be that vasospasm-induced ischemia. So the original insult itself, however, is going to be non-focal. So definitely take note of that, because that's an easy way that they can trip you up by giving hypertension as a risk factor for both of these. And then you're really stuck. You're not sure which one was the actual cause. And so how do you diagnose? Well, same exact way. You're going to do a CT non-con of the head. And so you always want to get CT non-contrast if you're expecting there to be a bleed in the brain. That's like the quickest, fastest test that you can get that's going to help you diagnose these patients with head bleeds. And so if that doesn't really help, then you can either do like a CTA or an MRA. Those are kind of second line options that can help you out as well. So let's dive a little bit deeper into the management. So now we're getting really to the step 2 type stuff. And so the management is going to be controlling your intracranial pressure. So you wouldn't want to give any of those nitro drugs like I'd mentioned. You also want a systolic blood pressure less than 200. So the subarachnoid hemorrhage, if you remember, is less than 150. For the parenchymal hemorrhage, it's going to be less than 200. So that's a little bit different. And with these patients, you only do surgery if there's like a mass effect or it's a really large hemorrhage. And so if you see like a mass effect from a really large amount of hemorrhage, then you can do surgery. So you can do a surgical decompression. And so the whole goal of that is to prevent herniation. And oftentimes it's like an uncal herniation that these patients will get. But the real goal is to prevent herniation. And so if you have a ton of blood in the brain, it makes sense that what's it going to do? It's going to push it to where there's less pressure, which would be downwards. And so you don't want herniation. These patients will often have hypertensive hemorrhages. And so I want to kind of just hone in on some of the little fine details real quick. So these will just be some of the details that people miss. And so they call them hypertensive hemorrhages. And you guys maybe have heard of these as called the Charcot-Bouchard. And a lot of people kind of like get confused and forget about this, so I want to mention it. The Charcot-Bouchard microaneurysms. And so these often are going to be in one specific location. And this is really helpful if you see it in a CT scan. They'll usually tell you because they don't expect you to diagnose this in the CT scan very often in terms of seeing these microaneurysms. But if you see it or it gives it to you on the question stem, it's often going to be in the putamen of the basal ganglia. And the big thing to know here with the putamen of the basal ganglia, it's because the lenticulostriates feed here. So if you remember that word, throw back to like M2 year, the lenticulostriate arteries feed up into that area. And so those are just small little branches off your MCA, your middle cerebral artery. And so that's the most common location is putamen. You can also see it in your thalamus, your pons, your cerebellum, but usually they'll go for the lenticulostriate branches. And so they're really prone to having the Charcot-Bouchard microaneurysms due to hypertension. So you basically how I work through this in my head, just to recap. So 1, they have hypertension. 2, they have some kind of a focal deficit. And so that's unlike your subarachnoid hemorrhage. 3, I see if they have any Charcot-Bouchard. And that's going to oftentimes be at the putamen from lenticulostriate. And then you want to have blood pressure control. So systolic blood pressure less than 200. And there's no like trick with this, like there's no nimodipine or anything like that, like there is with the subarachnoid hemorrhage. You basically just treat them with whatever IV medications you have. So you can either use hydralazine or labetalol or what have you. So that is how I will work through diagnosing intraparenchymal hemorrhage versus subarachnoid hemorrhage. So you have 2 things of homework to do as soon as we get off of this Zoom session. So homework. Number 1 is review autosomal dominant polycystic kidney disease and Ehlers-Danlos. And then number 2, I want you to review CT scan for subarachnoid hemorrhage and intraparenchymal. And I'll draw out for you kind of just like my own little version of it real quick, but obviously I want you to look at the actual CT scan. So let's say here's your subarachnoid hemorrhage, and we'll say here is your intraparenchymal. The easiest thing to notice between the two, and this is going to really truly be your dead giveaway if you can see this on your CT scan, is the intraparenchymal is going to usually be like a focal lesion like this. So it's going to either be in your parietal or your occipital lobe. So it's either in the parietal region or it's a bleed in the back of the brain. And so knowing your anatomy comes into play to help you out with these CT scans. And so usually it's going to appear as white on the CT scan. And so that's going to be your blood. And oftentimes it could also say like hyperattenuation or any of those other words to describe it. And then so for the subarachnoid hemorrhage, it's going to be in the basal cisterns usually. And so excuse my terrible drawing, but it looks something kind of like this. It's going to be almost like this weird star shape. And then it's going to be blood basically all throughout here. And you'll have to look it up if you haven't seen one of these CT scans, because if you see this on the test, this is literally a dead giveaway diagnosis. It's a free point on the test. There's nothing else that they're going to try and trick you with for it. So look up these 2 CT scans and you're going to feel really confident about diagnosing the difference between the 2 with everything that we've talked about. Does that help? You guys feel better about subarachnoid hemorrhage versus the intraparenchymal hemorrhage? Awesome. Awesome. Thank you guys for joining. That's all I got for today. I hope that was a good review for you. Take some of that with you, get some free points, and we'll have another one of these soon.
Thank you.
Absolutely.